And now I want to invite all the speakers to join me on camera, and we're going to start our moderated discussion. And I'm going to start just sort of reflecting first that a number of the speakers showed essentially walked us through a framework for health equity. And I think what's remarkable there is that most of the data that we've collected and much of the sort of research in central nervous system disorders that exists is really, Dr. Johnson built us the framework from the right side back in time and back in systems to the left side, but most of our data is on the right side, which is sort of these easily observable clinical and sort of cross-sectional, here and now and upstream, downstream health differences. And I wanted to ask, each of you whether what you think some of the key steps are for our field and for researchers and research on central nervous system disorders. What do we need to do to be able to understand the influence and the opportunities of some of these upstream or fundamental drivers of health in CNS disorders? And I'll start with Dr. Johnson for that, and we can move to other folks.
Yeah, really, really great question. And you're right, most of our work has really centered on the side. One of the fears is that we aren't collecting the data necessary to answer that question. And so I think it really starts with which we've done in like last year, really defining what we mean by structural racism, structural discrimination, developing measures for those different concepts, and then actually in our studies. And to do that, I also having talks like this where we're raising awareness about the importance of fundamental contributors to not just health disparities, but also to health outcomes, because these factors do affect a wide range of. So I think really centering this on measuring these factors and providing data, how these are shaping our environments and factors will be really important in this work.
Thank you. There's a question that came in. It reflects something that we talked about as a panel earlier. And the question is, are there any protective factors like family structure, social support, community cohesion that might mitigate the negative effects of neighborhood disadvantage? And I'll start with Dr. Hackman.
Thank you so much. I think this is a great question and really a central question because from the way that I think about it, it informs both our understanding of mechanism as well as potentially our understanding of prevention and intervention approaches, because those protective factors, those moderators, can also be areas of strength to enhance in communities. And at least for our work, I think it may be different if we separate broader work on neighborhoods and child development, in which certainly there's a lot of developing work around supportive and warm parenting, around social support, around a lot of the types of factors that were raised in the question, as distinct from this early research on neighborhoods as it's associated with different aspects of brain development, which is in its earlier stages. One of the things I do want to highlight in that is part of what we've become interested in, and some other teams have become interested in, are protective factors like school environments that can potentially be not only sources of curriculum and sort of explicit teaching and learning, but environments that really promote socio-emotional development, social development, and kind of health and development really across the board through both kind of formal and informal curricular strategies and environments. And part of why I want to highlight this is that I think as we continue to ask these important questions, like this one that's been raised, in addition to thinking about protective factors that may be on that more micro level scale, it's really important to also be looking at protective factors and these intervention approaches that are more at the level, a higher level context, that are modifiable by policy, modifiable by programs that can really help change structure in community, in addition to thinking about broader structural change. So
okay, Dr. Bodunobala.
Yeah, so we're actually doing some work right now out in communities where we're looking at whether family-supported management of really prevention of risk factors to get us to prevention of hypertension is more efficacious than just sort of what we do now, which is self-management. But that's only one level. And the second thing we're doing, though, is we're looking to see, is family supportive of, can we work with families to sort of achieve ideal health out in communities, especially we're looking at Latino and Vietnamese communities here in Southern California. And then the next level, though, is to what are the barriers that families have that are neighborhood level barriers, and bringing those barriers up to government agencies and other community stakeholders that have some responsibility for some of the structure of neighborhoods. And so this kind of multi-level intervention, and I think that that's going to shed some more light. I think there is enough evidence to suggest that social networks are protective, that collective efficacy, that neighborhoods that are more cohesive are neighborhoods that have less stroke, for example. And so I do think we want to play on those and really be positive about incorporating those protective factors into interventions. And then the last thing I would say back to your first question is the radical interventions are the ones that really address the fundamental causes of disease. And I don't think we've been brave enough yet to bring those kind of interventions to the table. And unfortunately, I don't think NIH has been brave enough to fund them. But that is ultimately where we have to go.
We saw a paper in JAMA Network Open in 2022 that simulated the effects of reparations on mortality, Black-white mortality differences using health and retirement study data. That's the type of thing, it was Catherine Himmelstein was the first author, and William Darity was among the authors. That's the type of thing I think you're talking about. And we can talk more about other studies that are looking at income increases to better brain health among children. There's a question in the that's been submitted by an author, an audience member, that says, "Are we ignoring an elephant in the room, given that 30 to 40% of the U.S. population seems not to only reject that structural racism exists, but think that the topic should be banned from research and discussion? How can we hope to implement change?" Dr. Martinez, can you lead us off with that one?
Yes, thank you.
Not a hard question. Go for it.
Thank you for that. So we can't deny that we have a very tough societal situation right now. But what I will say is that we also have one of the greatest public health opportunities that will come in our generation, especially when it comes to addressing environmental racism. We now, with the new climate package, are going to be having huge billions of dollars of money coming into environmental justice communities. And these things can go for work like weatherization. And as Dana talked about, how these changes in infrastructure can actually impact health through multiple different pathways, whether it be sleep or heart health or brain health. And so we can't change everybody's mind to be on board with understanding the legacy of white supremacy in this country. But what we can do is we can use the resources that are available and that are going to be more and more available in the next few years to try to tackle some of these issues. And as we address climate change, we can have the co-benefits of addressing some of these disparities in our communities that can have a major impact. And so I try to leave it on a more hopeful note.
Do any of the other panelists, I don't know if I'm allowed to bring Dr. Williams back in, want to speak to that elephant in the room of structural racism? Dr. Williams, your video's on.
Yes, so we are living in a very difficult time when there are efforts to dismantle it. I think one of the things I have said is that those of us who work on health need to do more work with communication experts and need to do more work with political scientists. We need to identify how to tell the stories of the challenges of disadvantaged populations in a way that connects emotionally with the general public so that they understand, they feel the pain. Now, we know there's an empathy gap, but there are strategies that can be used to reduce the empathy gap. And we need to be strategic about this work in the difficult political moment we're in.
Thank you so much. And I think that's especially relevant for CNS disorders that are so typically kind of these, contextual, social, and structural variables are really left out of the discussion. And people are, thinking about it more as biologically driven or genetically driven and not seeing the link. And so getting better at making those, having those conversations and making those links is great. I think that we might stop. I'm seeing that we only have 1 minute left. None of the other questions have sort of been collated for me, but we can move on to our next our break. I want to thank the panelists so much for their time and this really interesting and thought-provoking discussion. And we'll move on to our break. Dr. Hurd?
Thanks, everyone. Really provocative beginning, and we'll just take a 5-minute break, and then we'll come back and talk about social and community context for the discussion in terms of structural the structural basis of health disparities. So thank you, and we'll just take a 5 minutes break. So let's give everybody a stretch, and then we'll be back to continue. And please, continue to post your questions, and our speakers will continue to answer them. Thank you. See you in about 5 minutes.